Assalamu alaikum. It is my pleasure to present my presentation on common respiratory symptoms. I am Dr. Sheikh H.M. Mesbahul Islam, Associate Professor, Respiratory Medicine, Sylhet MG Osmani Medical College. There are 6 principal symptoms of respiratory disease. These are number 1, cough, number 2, sputum production, number 3, hemoptysis, number 4, chest pain, number 5, breathlessness, and last one is wheeze. The first symptom of respiratory disease is cough. Cough is a forceful expulsive maneuver against an initially closed glottis, causing characteristic sounds. Cough is an important reflex mechanism protecting the airways and a common symptom of respiratory diseases. Now let us see how cough is originated. There are multiple receptors, cough receptors present within the posterior wall of the larynx, trachea, and bronchi. The stimuli within the airways stimulate the receptors within the larynx, trachea, and bronchi, and via afferent nerves, that is vagal nerves, it reaches to the medulla oblongata. The efferent limb motor nerves passes to the laryngeal and respiratory muscles, and cough is originated. Mechanism of cough. There are 4 phases of cough: irritation phase, inspiratory phase, compressive phase, and last one is the expulsive phase. In irritation phase, neural activation from the solitary nucleus and can be cortically suppressed. In the inspiratory phase, glottis opens, diaphragm contracts, and thoracic cage expands. The third stage is compressive phase. Here, abdominal and thoracic muscles compress air against the closed glottis. And finally, the expulsive phase ensues. Here, abrupt glottis opens, rapid exhalation occurs, and high velocity and shear force allow airway clearance. Now let us see the types of cough or classification of cough. Cough can be classified acute cough, subacute cough, and chronic cough. Acute cough lasts less than 3 weeks. Subacute cough lasts 3 to 8 weeks. And chronic cough occurs more than 3 weeks. Acute cough. Acute cough is defined when duration of cough is less than 3 weeks. A patient with acute cough may present with normal chest X-ray or an abnormal chest X-ray. Acute cough with normal chest X-ray, common causes are viral respiratory infections, bacterial infections, inhaled foreign body, inhalation of eaten dust and fumes. Acute cough with abnormal chest X-ray, common causes are pneumonia, inhaled foreign body, acute extrinsic allergic alveolitis. Chronic cough. Chronic cough is defined when its duration stays or lasts long more than 8 weeks. A chronic cough, a patient of chronic cough may present with normal chest X-ray or may present with an abnormal chest X-ray. Chronic cough with normal chest X-ray includes gastroesophageal reflux disease, asthma, rhinitis or sinusitis, cigarette smoking, drugs, especially AC inhibitors, return dust or fumes. Chronic cough with abnormal chest X-ray. Common causes are bronchial carcinoma or lung tumors, tuberculosis, interstitial lung diseases, bronchiectasis. Patients with severe asthma or chronic obstructive pulmonary disease have prolonged wheezy coughing. A feeble, non-expulsive bovine cough with hoarseness, spasms, lung cancer invading the left recurrent laryngeal nerve and causing paralysis of left vocal cord. Cough from laryngeal inflammation, infection, and tumors are harsh, barking, or painful, and associated with hoarseness and is rasping or croaking inspiratory sounds of stridor. Tracheitis and pneumonitis typically cause dry, centrally painful, and non-productive cough. Nocturnal cough disrupting sleep is common in asthma. Occupational asthma and exposure to dust and fumes cause chronic cough that lessen during weekend and holidays. Occult gastroesophageal reflux diseases and chronic sinus diseases with associated with postnasal drip, and it is commonly occurs in daytime. Angiotensin and converting enzyme inhibitors cause a dry cough, particularly in women. When a patient with chronic cough comes into OPD or inpatient department, we should ask several questions. What are the questions that we should ask to the patients with cough symptom? These are: number one, how long the cough present? Is it intermittent or persistent? Is there any seasonal variation? Is there any diurnal variation? Is there any aggravating factors? Is there any relieving factor? These are the questions that we should ask in a patient with cough symptoms. What are the red flag symptoms associated with cough that should prompt a chest X-ray? The red flag symptoms associated with cough includes: if cough is associated with hemoptysis, breathlessness, fever, chest pain, or weight loss. The second symptom of respiratory diseases. This is sputum. What is sputum? Sputum is the secretion of lower respiratory tract below the level of vocal cord. If a patient with sputum presents in inpatient department or outpatient department, we should ask some questions. What are the clinical questions? The patient with sputum, these are: what is the amount of sputum? What is the duration of sputum production? Number 3, what is the color of the sputum? And fourth one is, we should ask about whether it is foul smell or not. Amount of the sputum, we should ask how much the sputum is coughed each day. Is it a small, as teaspoonful, or a large teacupful, or a scanty? In bronchiectasis, patients with bronchiectasis may cause large volumes of purulent sputum to be coughed up, varying with posture. Sudden production of large amounts of purulent sputum on a single location suggests rupture of lung abscess or a empyema into the bronchial tree. Large volumes of watery sputum with pink tinge in an acutely breathless patient suggests pulmonary edema, but occurring over weeks, like bronchoria, suggests alveolar cell carcinoma. Types of sputum. There are 4 types: serous, mucoid, purulent, rusty. The serous type, it is clear, watery, frothy, or pink. Common causes of serous sputum are acute pulmonary edema, alveolar cell carcinoma. The mucoid sputums are appearance is clear gray, white, or viscid. It commonly occurs in COPD, asthma. Purulent sputum appears yellowish or greenish in color. It is commonly seen in bronchopulmonary infections like pneumonia, bronchiectasis, cystic fibrosis, lung abscess. Rusty sputum. Rusty sputum appears rusty golden yellow. It is commonly seen in pneumococcal pneumonia. This slide shows the color of sputums: mucoid, mucopurulent, purulent. These are the color of sputums. Now let us discuss about the third respiratory symptoms: hemoptysis. What is hemoptysis? Hemoptysis is the coughing out of blood originating from the respiratory tract below the level of larynx. There are several or many causes of hemoptysis. The common causes of hemoptysis are acute bronchitis, bronchiectasis, pneumonia, lung abscess, tuberculosis, lung cancer, congestive heart failure, and unknown causes. Mitral stenosis is one of the cardiac cause that causes hemoptysis. In children, common causes of hemoptysis lower respiratory infections, or foreign body aspiration. Severity classification of hemoptysis. Hemoptysis may be classified on the basis of severity. Scanty hemoptysis, when blood is mixed, a tinge of blood or sticks of blood mixed with sputum, it is scanty. Mild hemoptysis, when the amounts 24 hours duration, the amount is less than 50 milliliter, it is mild hemoptysis. Moderate hemoptysis, when the amount of blood 50 to 100 milliliter in 24 hours, it is moderate hemoptysis. Severe hemoptysis or major hemoptysis, when the amounts of blood is 200 to 600 millimeter in 24 hours, we say it is severe hemoptysis. Massive hemoptysis. A massive hemoptysis is amount of blood more than 600 milliliter in 24 hours. This is massive hemoptysis. Life-threatening hemoptysis, when we say it is life-threatening hemoptysis, when the hemoptysis is 200 milliliter per hour or 50 milliliter per hour with respiratory failure. This is life-threatening. Severe, massive, and life-threatening hemoptysis needs hospital admission. Especially massive and life-threatening hemoptysis. If a patient comes with threatening and life-threatening and massive hemoptysis, we should admit the patient in the hospital. A massive hemoptysis may be up to 1 liter, either 500 milliliter of exported blood over 24 hours or bleeding at a rate of 100 ml per hour, regardless of whether the abnormal gastric or hemodynamic instability exists. This is massive hemoptysis. What are the main sources of bleeding in hemoptysis? The major sources are bronchial arteries, 90% cases, and 10% cases pulmonary artery are the source of bleeding. Now let us see the 4 symptoms of respiratory diseases. This is breathlessness or dyspnea. Breathlessness or dyspnea can be defined as the feeling of uncomfortable need to breathe. If a patient presented in outpatient department or inpatient department, we should ask several questions with breathlessness. What are the questions? Number 1, duration. How long the patient is suffering from breathlessness? Mode of onset. Is it acute or it is chronic? The third clinical questions on breathlessness is nature of the breathlessness. Is it intermittent or persistent or progressively increasing in nature? Is there any diurnal variation? Is there any seasonal variation? Is there variation on body posture? And lastly, we should ask, is there any aggravating or relieving factors? Patients with breathlessness present with either chronic exertional breathlessness or acute breathlessness. Chronic exertional breathlessness. The common causes are COPD, chronic asthma, bronchial carcinoma, interstitial lung diseases, chronic pulmonary thromboembolism, chronic heart failure, myocardial ischemia, severe anemia, and obesity. These are the common causes of chronic exertional breathlessness. In a stable COPD, initially the breathlessness is exertional. As this passes, it becomes progressively increasing in nature and increases in exercise. And lastly, in advanced stage, it becomes persistent. Bronchial asthma are often woken from their sleep by breathlessness with chest tightness and wheeze. Acute severe breathlessness. This is one of the most common and dramatic medical emergencies. Although there is a number of possible causes, the history and rapid but careful examination will usually suggest a diagnosis which can be confirmed by routine investigations, including chest X-ray, ECG, and arterial gas analysis. There are several causes of acute severe breathlessness. Number one, pulmonary edema. History shows usually chest pain, orthopnea, and cardiac history. Number two, acute severe asthma. There is history of asthma or taking asthma medications or wheeze. The third cause of severe breathlessness is acute exacerbation of COPD. Fourth important cause of acute severe breathlessness is pulmonary embolism. The next one is pneumonia. And lastly, metabolic acidosis. All these are the common causes of acute severe breathlessness. Orthopnea. Orthopnea is common in COPD as well as in heart diseases because airflow obstruction is made worse by cranial displacement of the diaphragm by abdominal contents when in recumbent. And so many patients choose to sleep in propped up. Now let us see the factors suggesting psychogenic hyperventilation. When a patient came in our department or outpatient department or inpatient department, when we call he or she is suffering from psychogenic ventilation, the common clues are inability to take deep breath, frequent sighing or erratic ventilation at rest, short breath holding time in the absence of severe respiratory diseases. Number 4, high score on Nizemengen questionnaire. Number 5, induction of symptoms during submaximal hyperventilation, resting end-tidal carbon dioxide less than 4.5%. And last one criteria is associated with digital paresthesia. Number fifth major respiratory symptom is chest pain. Chest wall pain suggests respiratory cause, cardiac cause, or musculoskeletal diseases. Causes of chest pain. Whether this is central, at first we will uh, classify whether this is central chest pain or non-central chest pain. The non-central chest pain includes pleural chest pain. It's commonly seen in pneumonia, bronchiectasis, or malignancy lung cancer, pneumothorax, pulmonary infarction, and connective tissue diseases may present with pleural causes of non-central chest pain. Non-central chest pain may occur in chest wall causes. This is lung malignancy, persistent cough, muscle strain or tear, costochondritis, very common in clinical practice, rib fracture, intercostal nerve compression, and herpes zoster. These are the common causes of chest wall causes of non-central chest pain. Central chest pain. Central chest pain usually occurs in midline structure. When the midline structures like trachea, cardiac, esophagus, gate vessels, or mediastinal structures causes chest pain. These are uh, central causes of chest pain. It includes tracheitis, massive pulmonary thromboembolism, acute myocardial infarction. Esophageal causes include esophagitis, rupture esophagus. Aortic dissection is another causes of central chest pain. Medicinal causes includes lung cancer, thymoma, lymphadenopathy, mediastinitis. All these cause may lead to chest pain. Pleuritic chest pain. Pleuritic chest pain is sharp, stabbing, intensified by inspiration or coughing. Number two, irritation of the parietal pleura of upper six ribs cause localized pain. Irritation of the parietal pleura overlying the central diaphragm innervated by the phrenic nerve is referred to the neck and shoulder tip. The lower six intercostal nerves innervate the parietal pleura of lower ribs and outer diaphragm, and the pain from the sides may refer to upper abdomen. And the last major symptom of respiratory disease is wheeze. A wheeze is a continuous coarse whistling sounds produced by respiratory airways during breathing. For a wheeze to occur, some parts of the respiratory tree must be narrowed or obstructed, or airflow velocity within the respiratory must be heightened. The most common cause of recurrent wheezing is seen in asthma, COPD, but these symptoms may occur in lung cancer, heart failure, and certain types of heart diseases. A wheeze occupy different portions of the respiratory cycle depends on the site of airway obstruction and its nature. The fraction of respiratory cycles during which a wheeze is produced roughly correspond to the degree of airway obstruction. Bronchial disease usually cause wheezing, causing that occurs in expiration phase of respiration. As a rule, extrathoracic airway obstruction produce inspiratory sounds. Intrathoracic major airway obstruction produce inspiratory as well as expiratory sounds. Distal airway obstruction predominantly produces expiratory sounds. The location of the wheeze can also be an important clue to the diagnosis. Diffuse process that affect most part of the lungs are most likely to produce wheezing that may hurt throughout the chest via stethoscope. Localized process such as occlusion of portion of the respiratory tree more likely to occur producing wheeze at that location. Hence, the sound will be loudest and radiate outwardly. The pitch of the wheeze do not reliably predict the degree of narrowing in the airway. The common causes of bilateral extensive wheeze is number one, asthma, and number two, COPD. What is a stridor? It is a variety of wheeze. Stridor, a special type of wheeze is stridor. Stridor is a harsh, high-pitched, vibrating sound that is heard in respiratory tract obstruction. Stridor is heard solely in the inspiratory phase of respiration, usually indicate an upper airway respiratory tract obstruction, such as trachea, epiglottis, and larynx. So, this is uh, all these are the major symptoms of respiratory diseases. I think all of you have understand or go through the books and will get fine. So I request you to go through books and um, thank you. Thank you very much. This is the end of my presentation on common symptoms of respiratory diseases. Thank you. Thanks to all.